I'd like to say a big hello and welcome everybody. I'm sitting in a very cold and very snowy Leicestershire. -7 this morning when I went to work. It's not that cold now, but I hope you're all nice and warm and cosy inside. We're delighted to be hosting this second webinar. This is a monthly event that the charity have arranged, and we've tried to pick speakers and topics that are very current and topical. And we'd be very glad to have any ideas that any of you have for other speakers and other topics that you'd like to see covered. So my name's Liz Darlison. I'm the CEO of Mesothelioma UK. I'm also a consultant nurse at the University Hospitals of Leicester. The only housekeeping I have really is, could you please make sure you remain muted? And if you have any questions that you'd like to pose to John Edwards, then please put them in the chat and we will be asking them on your behalf at the end of his presentation. So we will try and keep you muted as well. You have to excuse me, but I've got a puppy in the room who's just decided to make a nuisance of herself. It is live. So with that, like I say, a huge welcome. I'd like to introduce Mr. John Edwards, who is a consultant thoracic surgeon in Sheffield. He's been in that post since 2006. And prior to him leaving to work in Sheffield, I had the pleasure of working with him for several years in Leicester, where he completed an oncology PhD in mesothelioma. He is probably the first person that I met, really, that's absolutely dedicated to this disease. And he's been a huge supporter of Mesothelioma UK since the get-go and been involved with the charity's development at every stage. He's a great go-to person, a sounding board when we're trying to pick our way through the charity's developments. He's supported a number of organisations nationally and globally. He's been involved with the British Thoracic Oncology Group since it was established almost 20 years ago now, was chair of the Board of Trustees and is now still a member of the steering committee. But he's also involved in international organisations, the International Mesothelioma Interest Group and the International Association for the Study of Lung Cancer. And he's very well known and very well respected by all of his colleagues and peers and patients for his work in thoracic oncology. So it's a huge pleasure to welcome John. He was one of the surgeons involved in the MARS2 study, and he's going to give us a talk through surgery for malignant mesothelioma. And we're particularly interested to hear what next, of course, as you know, John. So thank you, John, and welcome. And again, if I could just remind people to keep themselves muted, we'd really appreciate it. Thank you, John.
Thank you, Liz, for a long and detailed introduction. I know many of the people coming on the webinar, which is fantastic. And it seems as if there's a fairly even split between patients and carers and their advocates and nurse specialists and also fellow medical clinicians. And so I'm going to try and have something here for everybody. And it may be that we get much more into the discussion to answer the questions that you're asking. So I'm going to try and whiz through my kind of regular talk about surgery and where we've got to with MARS2. And then we can hopefully have a fruitful discussion that is pretty open at the end. So thank you for that so far. So in terms of disclosures, I guess that Liz has already done those for me. I'm a thoracic surgeon, but for some reason I ended up with a PhD in oncology, which is, there's only a few of us that have gone that route, but hopefully it gives me a fairly broad background to draw upon when dealing with a disease that is multimodality. Many different types of treatment come together with mesothelioma. And I'm not a cardiac surgeon, nor am I a cardiothoracic surgeon, but I'm quite interested in the heart because it does that important role of pumping antibiotics and chemotherapy to the lungs. So in terms of other conflicts of interest, I guess my speciality, if you like, is to put myself put my head above the parapet and say that actually I've done quite a lot of trials of surgery versus no surgery. And that gives me a good understanding, I hope, that I can convey to patients and colleagues about equipoise, about understanding where there are grey areas which we don't understand. And you can see that of the 8 or so trials that I've been involved with, 7 of which have either completed or are open, and 4 of those are about mesothelioma. And I've been lucky to be involved in the original MARS trial, the MesoVATS, MARS2, of course, and MesoTrap as well. Lots of other research interests, but those randomized trials of surgery versus no surgery, I think, have been pivotal in my understanding of where to go with mesothelioma. So surgeons have been involved in mesothelioma for a very long time. And the original thoracoscopy, which started, can you believe, in 1865, was using telescopes that surgeons used for cystoscopy. So that was looking up through one's nether regions into the bladder. And you can see that, I mean, unfortunately, I don't have photographs, but they would have been using probably brass tubes with rudimentary optics on them in order to have a look also inside the pleural cavity. And it was Jacobaeus who was the person in, I think it was 1912, that introduced thoracoscopy in a big way, but it had already been undertaken, as I say, for 50 odd years before that. In the late 80s and early 90s, we started putting video cameras onto the telescopes, and you can see on the far left here the telescopes that are frequently used, and the other pictures are of me, dare I say it, and you can see that how we connect them to video cameras and video screens, and that's why, compared to the traditional sort of look through thoracoscopy, and I've actually got some of those old thoracoscopes behind me on the shelves. But when we started putting videos on it, we called it video assisted thoracoscopy, and that's where the terminology of mesothelioma started getting confusing and complicated. But that's what you can see there. And VATS, so-called, does have quite a lot of people around. It's quite a complex environment, but it allows us to do some fantastic things. And here you can see, dare I say, a patient with mesothelioma having their pleural biopsies. Latterly, as surgeons got more and more busy with lung cancer, we've also found that the chest physicians, the respiratory physicians, have started to undertake thoracoscopy of their own, and so-called medical thoracoscopy, using local anaesthetic as rather than a general anaesthetic to anaesthetize the patient and get inside the chest. And you can see here an example of a semi-rigid thoracoscope, a local anaesthetic thoracoscope, which allows them to take smaller biopsies. But the disadvantage of this technique is that they can't do quite so much inside the chest as we can as a surgeon. So that's really how we first got excited about pleural diseases. And in fact, my very first thoracic surgery operation in 1996 in Birmingham was a video-assisted thoracoscopic pleural biopsy of a patient with mesothelioma. But having said that, the big operations that we've done for mesothelioma have been going on for quite a long time as well. And the seminal paper by Eric Butchart, who has not long retired from practice in Cardiff, that was written when he was a registrar for Newcastle upon Tyne, included patients from 1959 to 1972. And this was the first proper description of extrapleural pneumonectomy or pleuropneumonectomy for malignant mesothelioma. So surgery to resect mesothelioma is nothing new. I think it's important to realize a little bit about the difference between palliative surgery and radical surgery. And palliative surgery is primarily aimed at removing the symptoms of the disease and hence improving the quality of life. And it may or may not result in an improvement in survival. So-called radical surgery, on the other hand, is trying to improve survival. And it may or it may not, or it might even cause detriment of quality of life. And so understanding the balance of how these things sort of play with each other is very important when we're dealing with surgery for mesothelioma. So I've not been to the Old Bailey yet, and I hope I never make it. But on the top of the Old Bailey, you have the figure here, and you can see when we're considering the balance of anything to do with any treatment in any branch of medicine, it's always about the risks and the benefits. And the risks are, in this case, obviously to do with a knife, are all about the side effects and the risks of the actual procedure or treatment that's being performed. But benefits can be considered, again, in those two ways for every condition, be it meningitis or a hip replacement or COVID. It's all about quality of life and length of life. And those are the two outcomes that we want to look at. And so when we look at the role of surgery in mesothelioma, it's very important to consider those two things. In terms of surgical options, there are a number of different things, and of course we'll talk about those briefly as we go through. But let's talk a little bit about what mesothelioma is. And these diagrams were drawn by my friend and colleague in the MD Anderson in Houston, in Texas, and so it's important that I acknowledge him. And this shows the chest being a box with the lung as a balloon blown up inside the box, with the pleura, the lining of the inside of the chest wall, which is also over the surface of the lung, and the balloon of the lung, which is only connected around the root of the lung here. And as I'm sure everybody listening knows, that mesothelioma starts on the inside of the chest wall. And the problem we have when it comes to surgery is that it starts off as quite a widespread condition. It's lots of little tiny specks all around the inside of the chest wall at the earliest point when we see it. It's not like, for example, a breast, lung, or bowel cancer, where we start off with a small lump that gets bigger and bigger and bigger. And then what that means is that eventually a little piece breaks off and goes elsewhere. The problem with meso is that we have at the time that we present with the disease, we have quite a widespread, geographically, quite a widespread selection of tumor nodules that then, as time goes by, they grow together and onto the surface of the lung and can encase the lung and the cracks between the lung, and can then grow into the muscle of the diaphragm and encase the lung so that it doesn't expand and contract properly. And we may get a trapped lung where the lung can't expand inside the chest with fluid around it. And this is a very different situation when it comes to attempting a radical surgery operation compared to, say, a regular lung, bowel, breast cancer. In those cancers, we may be able to remove the tumor and remove a margin of normal tissue around it, whereby if there's nothing that's gone elsewhere, we might be able to get that strong word of a cure. A cure, I think, is a difficult word to use, but it means ultimately the very best in increase in length of life. And the problem with mesothelioma is that we can't get that margin of an inch or two of all the tissues around these areas, because, to use the American terminology, there's expensive real estate all around here, and we can't remove the chest wall, the liver, the heart. And that's why I liken mesothelioma surgery to stripping wallpaper in a house. And what you want to do is to try and find wallpaper that strips nicely, vinyl. You know, you just breathe on it and it just falls off the walls. Whereas wood chip, you can sit there with your steamer pulling hard, it still doesn't come off, and eventually it comes off and it pulls down the plaster and the bricks, and you end up doing a lot more of a job. And so part of our job in selecting patients for surgery is to try and understand how it's behaving and whether it's something that we can actually achieve. But it's crucial to remember that we cannot remove it with that margin of 2.5 centimeters all round, whereby we can potentially get a cure. The very best we can do is to remove everything that we can see and feel. And that is the intention with surgery. But of course, the most simple surgery is symptom control. So for example, a talc pleurodesis, where we suck all the fluid out, we squirt talc inside, we try to get the lung to expand and stick. And this can work very well. I have had patients that have had even 7.5 liters of fluid at one point inside the chest. And so removing those 7.5 liters can make somebody's breathing substantially better, but it's not going to make any difference to the length of life. So the question is, are there types of operation that may achieve either an increase in length or quality of life, or even both? So starting at the bottom rung of the ladder, we have so-called VATS partial pleurectomy. So this again is video-assisted thoracoscopic surgery. So this is keyhole surgery, where typically when we were performing this in big numbers, we were using 2 or 3 holes around the side of the chest, maybe an inch or 2 in length, to enable us to peel everything off. So we would start off with a situation like this, often with fluid inside the chest, and peel everything off the inside of the chest wall. Peeling it off the chest wall is quite easy. Peeling it off the diaphragm is nigh on impossible, as is peeling it off the pericardium, the sac around the side of the heart here. If we're lucky, we can peel it off the surface of the lung, but to do so is very difficult. So with the best will in the world, we can maybe take away 75% of the tumor with VATS, with keyhole surgery. But that means leaving 25% behind. And so the question then is, well, what does that mean in terms of quality and length of life? And that's where the role of clinical trials has come in terms of research, where we've done studies where patients have been allocated at random. Now, I'm not going to talk about why that is a good idea, but that is the best way of finding out whether a treatment works, because it avoids bias between the two groups. Briefly, if I were to operate on all the younger, fitter, stronger patients and not operate on the more late stage, older, less fit patients, and I were to compare which group and which one did best, it would be quite likely that the younger, fitter, stronger patients did best. Now, would that be because they had surgery, or would it be because they're younger, fitter, and stronger? And that's where clinical trials come in, by allocating patients at random between the two groups, so we get rid of that issue of so-called selection bias. And so the MESO-VATS study was one of those studies that we put together to try and work out whether keyhole surgery to peel off this tissue made a difference. And those results were published, and I'll come back to that a little bit later. At the other end of the scale, we've got extrapleural pneumonectomy, and this is where we have a situation again where we start off with a lung that looks like this, but we're going to take everything out of the chest. We're going to peel everything off the inside of the chest wall. Then we're going to remove the diaphragm and the pericardium and the whole lung, because that way we effectively can really try and remove everything that we possibly can. We end up with a great big hole, and we leave a patch on the diaphragm and a patch on the side of the heart. And so the question then is whether surgery makes a difference in this instance. And again, this was an operation from Butchart's days onwards, where the younger, fitter, stronger patients had surgery and the older crocs didn't. So when we look at the results, we thought it was a good operation, but is it because we were good at choosing the winners, or is it because surgery worked? With extended pleurectomy decortication, again, it's a slightly different situation once more. And this is an operation where we do everything that we can to remove tumor, but we intend to leave the lung behind. And so we peel everything off the inside of the chest wall. We do remove the diaphragm almost always. We do remove the sac on the side of the heart, the pericardium, almost always. But then rather than remove the whole lung, we then spend, dare I say it, another 2 or 3 hours very carefully peeling the tumor off the surface of the lung and trying to get the lung to expand. We often have to put patches on the diaphragm and on the pericardium, so we end up with that situation. And so this is the so-called MARS2 trial, where patients were allocated at random after having some chemotherapy and before having more chemotherapy, between either having an operation or not. So that gives us an indication as to the different types of operation. When it comes down to the evidence, as I said, the important things to try and work out from the clinical studies we've done are whether the quality of life is better with surgery, and whether the survival, the length of life, is better or not. And so these are the data that have come from the studies. So the MESO-VATS study was presented in, if I remember rightly, I think it was 2013. And this was the randomized study that Robert Rintoul led. 196 patients were randomized between getting just a pleurodesis or pleurectomy as well. And when we looked at the quality of life, and this is a very well-used quality of life measure called EQ5D, it's 5 simple questions that the patients asked. Now, these are statistical plots, so it shows the average, the median score, but it also shows, sorry, the mean score, but it also shows what's called the 95% confidence intervals. Now that's a bit statistical, but it basically means if these 2 lines of the different colors are completely separate, then we have a properly significant result. So you can see that the quality of life in the surgery group, in the red here, was a little bit better. It was a little bit worse a month after the procedure than talc alone, as you might expect. And then it got a little bit better, whereas the talc ones seemed to get a little bit worse. but you hear me saying a little bit. The reason being is that the only statistically different result was the quality of life at 1 year after surgery. And so that wasn't really good enough for the surgical community around the world to say, oh, this is a fantastic result, we must do this operation. What about the other side of the benefit, the survival? Well, when the survival was looked at, there was no difference at all between the survival. So for those that aren't medically qualified, a survival curve starts at time 0 when there's 100% of people alive, and as time goes by, dare I say it, people do succumb to the disease. And if we see separation of these two lines, then that can reveal a statistically significant test when the p-value is less than 0.05. But you can see here that the survival rates were pretty much the same between the 6th month and the 12-month marks. There wasn't any real difference between the two. So quality of life a little bit better, but not a lot, and survival no different at all. Extrapleural pneumonectomy in the MARS2, well, it has to be said that it's very important to realize that the MARS2, so the original MARS study was a pilot study. So the main aim was to assess the feasibility of randomizing patients in 1 year, 50 patients. The intention was that it might require nearly 600 patients in a so-called fully powered study to truly find out if there was a difference. But nobody knew whether we could at all randomize patients between such a big operation that is potentially a life-changing operation versus not. And that in itself was really controversial. So it was a feasibility study. And that's why when we come to consider the results, we have to make sure that we're wearing our appropriate PPE and bear in mind that there's not actually a huge amount that we can truly and honestly say about the original MARS study results. Apart from it took longer than expected to recruit, the compliance with the study protocol was not very good, and to a great extent, the results have been overinterpreted. The feasibility study, as I mentioned, was never powered to examine differences in survival. And really the only crucial conclusion from the MARS study was that we didn't feel that it was going to be possible to run a fully powered 600 odd cases study into that study. What was the effect on survival? So bearing in mind the fact that the numbers here are tiny, but what we saw was that there was no great increase in survival that we could see or signal that there was going to be an increase in survival between the two groups. And when it came to quality of life, yes, as one expected, the quality of life dropped after surgery, and then it came back up again, but it never quite reached the level of the patients that did not have surgery. And again, there was no big difference there, no signal of positive effect that really encouraged the surgeons in the UK to pursue trying to randomize 600 patients. And when we presented these results in 2011, there was a furore in the meeting room in the conference in Amsterdam, and Professor Treasure was accused of all sorts of crimes against research that continued in the literature for some considerable length of time. And this is the sort of things that were said, a sense of perspective and an inconvenient truth, and that the conclusions were not supported by the results. And but ultimately what happened in the world was that practically everybody stopped doing extrapleural pneumonectomy. So whether we respect the results or not, it did indeed happen to change practice. So what about extended pleurectomy decortication? So this is the MARS2 study where we have got to, and it has to be said, with a great success. So thinking about these two benefits, so the problem being, again, this is an operation that we've been doing in the UK since at least 1998. I can still remember very clearly the name and the name of the daughter of the very first patient that we operated on in Leicester in 1998, and Mr. L. Muck. He, when we talked to him about it, we really didn't know very much at all, but we knew that we wanted to operate on the younger, fitter, stronger patients, and he was certainly one. And we didn't really know a huge amount about the risks at that point in time. But over the years, from say 1998 until say 2013, 2014, we did a lot of operations. And so we knew very much what happened in terms of the risks of the operation and also the quality of life after surgery. We kind of knew what was happening there. So there were studies from 2 centres in particular around the world that published 2 or 3 times each, and they looked at the quality of life in terms of the different symptom scores, and I'm deliberately not showing you these very clearly because we don't really need to, and also things like the perfusion of the lung and the lung function tests, the blowing tests, to see what happened before and after surgery with the extended pleurectomy decortication operation. And it suggested that in some patients that did seem to have a slight improvement in lung function and potentially also in quality of life. But equally, it's important to note that if you have somebody that has normal quality of life, there's nothing that I can do as a surgeon to improve your quality of life beyond 100%. So really, we need to think carefully about whether we should be operating on patients with no symptoms. On what justification would that be? Because it can't really be quality of life very soon after surgery, although it may be that quality of life later on after surgery could be better than if they had not had surgery. So there are some interesting concepts that we need to think about, even now as we finish MARS2. So this gives an indication as to the number of people, and this does not list all the people that have been involved in MARS2. For example, I know that there are at least another half a dozen surgeons, including my colleagues that are not on this official slide, but without whom we would not be able to do the study. And in each of these centres, there's a little cottage industry of people, 4, 5, 6 different people in every single of these centres that are involved in every part of the study. But you can see that it does take a lot of undertaking to conduct a trial such as MARS2. The study itself was done, and this is the sort of study diagram, if you like, starting from the top in terms of looking at the eligibility of patients. And patients had chemotherapy to start with. The reason for that is to see if we could find who had disease that progressed despite chemotherapy. So after 2 cycles of chemotherapy, with a couple of cycles and another CT scan, if we found that the CT scan got worse, that might tell us that actually the time spent for the patient might not be best served recovering from a big operation, but maybe should be better spent seeking alternative type of chemotherapy. And so for those patients did not progress to surgery, and I'll talk a little bit about that proportion a little later, but those that did have a favourable CT scan and remained fit enough were allocated at random between either operation followed by more chemotherapy or just chemotherapy alone. And you can then see that follow-up was conducted at lots of different time points to find out, A, whether they were still alive in terms of working out length of life, but also conducting quality of life questionnaires. So in theory, it may not be, perhaps, until another 5 years before the very last patient has the very last 5-year survival, if we go that far. It may be that we don't have to go that far in order to get a result, because equally it's important that we make progress in terms of determining what we should do next at the earliest opportunity. So I'm grateful to Eric Lim, Professor Lim from the Royal Brompton Hospital, for passing me the slides that are up to the minute. So the last patient in MARS2 has just been randomized, and their treatment hasn't been completed, but 335 patients were allocated. We needed 328, and the study was kept open whilst those patients that were in progress were allowed to come to randomization if they wanted. And so it has ended up that there have been 335 randomizations. And you can see here that the target that Professor Lim set us to deliver, we started off okay, then we had a little bit slow, and then we picked up again, and then something happened at the beginning of 2020. I'm not quite sure what happened, but we did have to pause recruitment for a while, but then we picked up again, and it's been a little bit of a struggle to get there, but to get to the end there is extremely useful. And you can see here the wide number of centres that recruited patients into the study over the course of time. And I'm extremely grateful for those that I can see are listening from the centres in the the north of England and the west of England and Wales who sent patients for consideration to us, and you can see what a big effort that's been. So I guess, you know, the big thing really is that, you know, we're not going to get results very quickly. It's going to take time, even for understanding the results of surgery. You know, how long did people stay in hospital? What were the risks and the toxicities of surgery? It's going to take a while for those to mature and for all the results to be filed before they can then be analysed. So it's not as if I can share with you, for example, the in-hospital surgical outcomes, although I expect that Professor Lim would be keen to present some of those when all those data have been returned. So that it's not as if I can say much more than the fact that we've completed accrual to the study. We'll now need to finish treatment for those towards the end of the study, and then conduct follow-up and see how we go with the quality and length of life. But for what proportion is this an option? And this is something that it may be useful to consider for the future. So it gives you an idea of what proportion, for example, in Sheffield that we've done. So the study was open for about 5 years, and in that time we screened in Sheffield mesothelioma MDT 300 patients, and we believe that this is every patient within our cancer network who had mesothelioma, and that includes people in their 90s who died the next day. Just as it includes people in their 40s who are still alive. So they were all screened as part of this process, and I believe that about 1/3 of those would have been eligible for recruitment into MARS2. Having said that, in Sheffield, our data suggests that of those 93, 40 enrolled, and then when it came through to the process of random allocation, half of those did not make it through. So for whatever reason, they withdrew, and I can't really share those reasons just yet. But that gives you a relatively low proportion of patients. 46% of those that were enrolled were randomized, but only 6% of all our geographic area patients ended up going as far as being randomized, although 1 in 8 or so, 13%, were potentially appropriate for the procedure. We, of course, also received a good number of patients from outside. So of the 522 patients in total, 224 came from outside, from Liverpool, Manchester, Newport, Birmingham, Wolverhampton, Middlesbrough, and Leeds, and so forth. And when we look at those patients, these are a little bit more selected. So a greater proportion of those that we screened, because they'd already been screened locally, were then enrolled. But more interestingly, of those that were enrolled from the other centres, there was greater retention. So whether that means that they were just a little bit more motivated to want to come to Sheffield than our local patients, and therefore, because they were enrolled, they pushed hard to keep in the study, or what, I don't know. But it would be interesting to look at those data at some point and work it out. But you can see there that of the patients that came to us from other centres, 75% of those enrolled ended up being randomly allocated. So that gives you some idea, as best as I can, in terms of giving an idea as to what proportion of patients would be eligible for the study, were enrolled and saw it through past the first 2 cycles of chemotherapy. I know a little bit about the outcomes of those groups, but it wouldn't be right for me to share that here or at this point in time. So this really is my kind of last slide. So Liz will need to unmute herself relatively shortly and assimilate the various questions. So ultimately, we know that MARS2 will report results in at least another 2 years. And so if we want a 2-year outcome on every patient, and I think that would be a good idea, it's going to be early 2023 before we get a result. So that means that there's going to be potentially 5,500 patients in the UK, let alone all those around the world, presenting with mesothelioma. So what are we going to do in the meantime? Should we stop operating? What was the experimental arm in MARS2? Was the experimental arm doing surgery that we'd been performing for 20 years? Or was it actually the experimental arm was not doing surgery in patients that we would normally have done? So you can put it in different ways, and ultimately, there are international guidelines about this, but we need to think carefully as a community of surgeons, of respiratory physicians, oncologists, patients, mesothelioma nurse specialists, everybody. We need to perhaps come to some form of agreement as to how we might proceed, but accept that our feelings might differ. And it may be that there are some groups that feel that it is worth pursuing and others not. What about immunotherapy? So we know that the next big thing is going to be immunotherapy on the basis of the study of ipilimumab and nivolumab. I'm trying to say it slightly better than Boris does, but these drugs are known to be very effective and potentially even better than chemotherapy in certain patients. And we know that NICE are going to say something about their use in patients, and we know that there is some access currently. So where does immunotherapy go? Should we be doing a study looking at the interplay between immunotherapy and surgery? And that's something that has been done in some centers around the world, but actually we're in the best place in the world to conduct these sorts of studies. So should we be pushing ahead, as some of us are trying to open up some form of research study looking at the combination of immunotherapy, chemotherapy, as well as surgery, and look at the toxicities of that? And if we are going to offer surgery, how do we do that? Where? Who's going to do it? Which patients? And these are the sorts of things that I think we need to discuss. And if I may, Liz, I'm going to leave that open at 16:40 on the dot, and open the discussion to you and others to see what we think of where we should go next.
Lovely. Well, thank you, John. That was an absolutely thorough journey through mesothelioma surgery. Can I ask you to stop sharing your screen? Is that okay?
I can stop sharing my screen. There we go.
So I guess the first thing I'd like to ask is, Mavis has actually alluded to this a little bit. So why don't we do extrapleural pneumonectomy as opposed to extended pleurectomy decortication? So just to remind people, extrapleural pneumonectomy was the procedure that John described that actually did all of that surgery and removed the lung. And the extended pleurectomy decortication preserves the lung. And so why don't we remove the lung more often?
So that's a very, very good question. And I guess it's almost from a surgical, I mean, there are different opinions, different perspectives that we need to take into account when considering doing something for which ultimately we haven't got a huge amount of evidence either in favor or against. And we have to take into consideration the surgeon's viewpoint as well as the patient's viewpoint, and I guess to another degree, the health services viewpoint as to what is appropriate in this setting. So let's think about those different things. So if we go from the patient perspective, what would the patient expect if this was to happen? So when we're looking at, and if we look at the evidence, what we can say is that the likelihood is that somebody's quality of life would drop after removing the whole lung, and that quality of life would stay below what it was before the operation, and probably not get back to where it was before the operation. And that's because the best evidence we've got is from the MARS2 study, albeit very small. There have been some other studies, like comparing the quality of life before and the quality of life after extrapleural pneumonectomy, but they've had mixed results and haven't really shown that there is a chance of definite improvement in quality of life. And when it comes to survival, that's the other benefit that we might get. The evidence isn't really there. So I would be saying to a patient, if we were considering an extrapleural pneumonectomy, I'm going to make you feel worse and you might not live any longer. And that's really what we've learnt from the science over the years. The problem is that there are also patients that have done very well after extrapleural pneumonectomy.
And they're often the ones that are rightly so, celebrate the fact that they are survivors. And I acknowledge the fact that we need, in this disease, we need survivors. But the problem being is that when you look at individuals, you might lose the fact that there are also people that have not done so well who no longer have a voice. So it becomes very difficult. And from a health service perspective, what they want to see is value for money. And so this is a big operation that costs a lot of money, and there isn't really any evidence in favor of it. And would we not be better off putting our resources into immunotherapy and giving immunotherapy to more people for longer, for example, when we know that there are qualities and length of life improvements that can be offered to a greater range of people? So I think it's difficult, but I think ultimately the fact that extrapleural pneumonectomy is very rarely done worldwide now is because surgeons and patients no longer want it.
A few more questions coming in. So which surgeons did the operating in MARS2? Thank you, Simon, for that question. Was it local surgeons or surgeons at specialist centres?
So we worked very closely. The way the study was set up is that we saw the data from MARS. There were concerns about the ability to deliver surgery safely. And so what's happened is that the study was initially set up with just 2 centres, Leicester and Sheffield, being the surgery centres for the first 50 randomizations. And after that, it was then expanded to other surgical centres. And so Glasgow and Barts in particular were brought on and increased the number of surgical centres. But we worked very much on the lines that actually, if we wanted to minimise the risks, it made sense for an operation that wasn't that popular nationwide amongst thoracic surgeons. It made sense for the patient to travel to the specialist centres. And we acknowledged the support of that Mesothelioma UK brokered to enable and facilitate that for patients, and also the fact that it's very hard to be hundreds of miles away. But the point about that means is that we hope that we've been able to minimise the risks to our patients by operating in specialist centres.
And I guess just to reassure people that, I don't know about you, John, but I feel quite confident now, far more confident than I did a few years ago, that if MARS2 is supportive of extended pleurectomy decortication, we've got a really good team of surgeons across the country that will be able to roll this procedure out in more than we had in the MARS2 study.
And so I've been talking just in the last few days to one of the biggest recruiting oncology centres and to their surgeons, and we talked about this at length. We said, well, what do we want to do? And he said, well, actually, if we do have appropriate patients to consider EPD, can you continue to operate on them? And I said, yes, of course we can. And he acknowledged that actually in the time it would take to learn the procedure, which would require coming to see the operation and bringing a patient and operating on them here, and then going back and us going over there and making sure that the whole team, because it's not just the surgeon, I'm a small part of the team, it's probably the anaesthetic support and the critical care staff and the ward staff that also need to learn. It's not just the surgeon. And exactly, and so there's lots of people that need to be involved in the aftercare of the patients, and so if we do find that this is something that's appropriate to roll out, yes, it's going to require a lot of training. So I expect that in the next few years, the operations that do get done will be performed in those specialist centres.
Okay, we've got some more questions, so we probably need to speed up and get through some of these. So Matt said, thanks for a great presentation, and wanted to ask about limited pleurectomy. In other words, leaving the diaphragm and the pericardium intact. And if what are your thoughts about that? And is it only for patients not fit enough for extended pleurectomy?
So the question there is if we can almost go back to the data from the Mesothelioma study. So the idea of leaving the diaphragm behind is to try and maintain that very important muscle of breathing. So a question is that needs to be considered is whether keeping the diaphragm results in better breathing afterwards. And it might well do. But the problem is the likelihood of being able to achieve the goal of so-called radical surgery, of complete macroscopic resection, in other words, getting out everything I can see and feel, is that much more difficult. So this would end up being what's called a partial pleurectomy. And so effectively, you know, even if we do a fantastic job on the lung and elsewhere in the chest, we are left with so-called macroscopic disease with lumps and bumps. And what that means is that the results are back